Paper number 4, effect of buprenorphine on non-high density lipoprotein cholesterol levels in statin-treated patients with elevated cholesterol. The TRANSLATE-TIMI 70 study presented by Dr. Brian Bergmark. I think what is happening is many of the patients that we see with hyperlipidemia are mixed hyperlipidemic patients. They have high triglycerides and they have apolipoprotein B elevations and so forth. And in this study, they say, well, with the statins, we can do a very good job in lowering LDL cholesterol down, but still we have many patients with a residual increase in lipid material that maybe could be overcome by a different approach. So this is actually the story, is a very interesting one. I think this drug we have been talking about the last 3 years or so, and that is angiopoietin-like protein 3 or ANGPTL3. What this drug does inhibits a lipase, which prevents the most of the lipid material to be metabolized. So the levels of lipids increase, particularly triglycerides and some of the non-HDL cholesterol. So what was found is that this was actually in humans, I believe, that a mutation of this angiopoietin-like protein 3 decreased all the lipid levels, thinking that maybe what we should do is to neutralize this drug, since what it does is the opposite, prevents metabolism. Let's now doing this with an antisense oligonucleotide targeting, which is the ANGPTL3 messenger being neutralized. Well, this is very fascinating using this inhibitor. It was a number of studies. I still remember last year we commented on one in this hour, but there was a phase 2 study that we commented on. But at that time, there was a single dose and not enough follow-up. So this study basically is the use of a new lipid-lowering agent at different dosages over a period of time in trying to lower the non-HDL cholesterol, which is a number of lipid molecules circulating in blood being in high levels. So basically, this is a study, as I mentioned, with a number of dosages. The drug is given subcutaneously, and the dosages go from every 4 weeks to bi-weekly and different levels of dosages, as I mentioned. And the primary endpoint was the % change from the baseline of non-HDL cholesterol at 24 weeks. This is actually 24 weeks is not too long, but enough to see the effect of the drug. And secondary endpoints were individual lipid variables. 286 patients were randomized, 44 to placebo and 242 to buprenorphine. Now, the results I like to call attention is certainly a decrease in terms of these patients were very well treated with the statins, by the way. And the decrease in the non-HDL cholesterol was about 25%, more or less depending of the amount of drug being given. The injection site, however, has some reactions and so some elevation of liver enzymes too. So this is something to take into account that is not a free ride with using this medication, at least for a period of time which is relatively short. So I'd like to conclude by saying that buprenorphine, which is an inhibitor of the mentioned that I mentioned to you, the ANGPTL3 is an inhibitor administered at monthly equivalent doses from 80 to 320 milligrams. This is what they come up with. Significantly reduce non-HDL cholesterol and additional lipid parameters. Injection site reaction and liver enzyme elevations were more frequent at higher dosages, but the results were less of benefit if you lower the dose anyway. And there was a dose-dependent increase in hepatic fat fraction. Well, it's a new approach. We have been talking for the last 2 or 3 years. And maybe Viviany, can you tell us how you react to this, to the point that, in fact, many patients come with mixed levels of lipid materials and are elevated.
I think, this is a very exciting space. It's dizzying, I think, for the non-expert to consider all of these new agents, but it speaks to what may be a real paradigm shift in how we think about lowering cholesterol, or at least very clear surrogate markers of future cardiovascular events, LDL being one of them. And so, ANGPTL3 has emerged as a incredibly compelling target. And there are potentially multiple ways of lowering risk from this biomarker, so to speak. And so, these kinds of studies where meticulous attention is paid to doses and how it impacts patients in terms of sort of collateral damage, so to speak, to liver function, I think is really important, as well as, side effects from things like injections. But I see that in the future, we're not necessarily going to be limited to weekly or biweekly or monthly monoclonal antibody injections to lower the concentration of these proteins in the system, when we think about mRNA therapies and even potentially vaccination in the future. So I think this is very much a step in the right direction, and we need to be very clear about risk versus benefit for our patients, especially as we consider a younger and younger patient population to start treating.
Thank you. Biykem?
Of course, it's very promising. I'd like to also, perhaps point out that there were hepatic fat fraction changes along with LFT changes. So reversibility of those changes, the structural changes in the liver, will be quite important. Especially given the fact that we're going to consider these agents after statin optimization, which can have impact on the LFTs. Now seeing another agent that is in a dose-dependent fashion has affected the LFTs and maybe even the structure in the liver, especially with the fat fraction. It requires further inquiry into how reversible these are and which patients should not be treated with these. As we know, the non-HDL lipid abnormalities commonly seen in individuals with hepatosteatosis, as well as fatty liver abnormalities and obesity. So these are important. And then the other concept is re-exposure or repeated dosing with the anti-drug antibodies. I think in significant percentage there is a drug antibody, and whether this is going to be a one-time and which patient, these are probably to be determined.
Thank you, Paul.
I think this does provide us with a new insight into how we're going to manage these patients, and has a tremendous potential. The first thing, though, that jumps out at me is cost. Is this something we're going to be able to afford to give to a large population of people who probably are in need of these types of novel therapies?
Thank you. Thanks very much. Joanna, you have something to add here? Are you excited about all this new lipid stuff coming in?
Only in theory, because I think, as Biykem really articulates brilliantly, the downside of this drug's impact on your liver, the presence of anti-drug antibodies in 44% of patients by the end of the course of treatment, those are pretty concerning signals. So I'd be really interested to see how that risk is balanced with the treatment benefit.
In a longer term, actually. Yeah. Okay, thank you very much. Let's go into study number 5, the PACMAN AMI study, randomized clinical trial, effects of alirocumab on coronary atherosclerosis in patients with acute myocardial infarction. Well, we all know about vulnerable plaques and plaque ruptures. And the question is, what about in patients who have a myocardial infarction and you have the most modern imaging technology to look at the arteries that are not the culprit lesion? And since recurrences are important, can we follow these patients with those lesions using this PCSK9 inhibitor in patients who are very well treated with statins? This was the study, is to determine the early administration of PCSK9 alirocumab on top of high-intensity statin therapy in patients with myocardial infarction, 2 arteries being visualized with intravascular ultrasound, near-infrared spectroscopy or NIRS or optical coefficient tomography, or OCT. 52 weeks of follow-up, 1 year. And to look at imaging in these two baseline and after 1 year in patients that were randomized. We are talking about the 300 patients actually randomized into placebo plus rosuvastatin 20 milligrams versus alirocumab subcutaneously twice weekly, bi-weekly as the placebo. And these patients, as I mentioned, were followed for a period of 1 year. The primary endpoints were certainly with IBUS was the possible hypothetical decrease in atheroma volume, with the NIRS, the lipid core burden index, and then we have the, interestingly, with OCT, what you can do is to look at the covering cap, the fibrous cap is getting thicker. So with the other two technologies is looking at whether the lipid material is decreasing in the volume of the plaque, and with OCT, if the cap that is protective is more thickened. The study was performed in 300 patients in 4 different countries: Denmark, Austria, the Netherlands, and Switzerland. And here are the results. First, the LDL cholesterol levels with this drug, they certainly dropped from 154 to 23, so it's working. The change, the percentage change of atheroma volume is significant, but frankly, is 2.1% less than on baseline. And I am not sure how, to me, it's very borderline, but with 300 patients and 2 arteries being explored that have some obstruction, may be meaningful. Then we have interestingly, was the thickness was significantly increased with OCT. And this is very fascinating to me because it was actually quite significant. And finally, there was some side effects here with the drugs. Local injection, 6.1% with a reaction, and in the placebo, 3.3%. And actually, I have to say that the study certainly shows that this drug, lowering LDL so much, has a significant effect on the artery over a period of 1 year in lesions that have a significant deposition of fat. So in conclusion, they say, compared with placebo, alirocumab initiated in the setting of acute MI on top of high-intensity statin therapy resulted in greater decrease in the 3 aspects that I mentioned, with increase, I would say, on the thickness of the cap of the lesion. These findings indicate incremental coronary plaque regression, lipid core reduction, and plaque stabilization, and provide a rationale in favor of early initiation of very intensive LDL cholesterol level or cholesterol lowering in these patients. I want to emphasize, which I didn't, and it's a mistake, this is done very soon after the acute MI. So this is not like you do a year later. This is a type of treatment that is presented just at the time of the acute phase of MI, with the follow-up, as I mentioned, over a period of 52 weeks, almost 1 year. Okay, so let's see, Paul, what do you think?
Well, I think this gives us a window into the mechanism for improved event rates in patients who have their serum cholesterols dramatically reduced after an acute event. And I think it's important mechanistic information to have, and it pretty much supports our hypothesis that lower cholesterol is better, and that you can see the pleiotropic effects of these drugs that lower lipids in a very short period of time. And this tells us that maybe one of the mechanisms that results in such improved clinical outcomes is lower plaque burden and plaque volume of the atheroma, as well as stabilization of that fibrous cap. So I think this is great stuff, and I think that it is going to give us more insight and further encourage us to try to get lipid levels as low as we can.
It's interesting, Viviany, but those of us who work on vulnerable plaques, there are so many. So it is not surprising that when you have an acute syndrome, you still can get into the fat of other plaques. People think there's a single plaque that is the vulnerable. This is at autopsy. Post-mortem is a single plaque. Pre-mortem are many. But this explains why the study was good. So what do you think?
I agree. I think it's fascinating that they actually used a multimodality imaging approach, right? These were all intravascular techniques. So there's all kinds of limitations. Like you said, they leveraged an acute MI setting in order to do that, because otherwise it's hard to justify. At the same time, though, they used the most sophisticated technologies, right? Including ultrasound, OCT, near infrared, to try to find kind of complementary mechanistic signals, which I think that they saw. It is fascinating as we think about how our advanced imaging technology is, again, undergoing a revolution. Even in the non-invasive realm, we're going to be able to do this at a much broader and larger scale, looking at entire plaque burden when we think about how, to leverage artificial intelligence and convolutional neural networks to be able to quantify the entire atherosclerotic burden with or without certain high-risk features, and to correlate that not just to future events, which are incredibly important, but also to important, genetic and other epidemiologic demographic information. And so I think stay tuned. I think this field is going to explode. And I think it's important to leverage the technologies that we have to understand mechanisms behind the drugs that we find to be therapeutic.
Do you think, Viviany, in the future will have non-invasive technology for the coronaries to look at the plaques, fat, so forth?
So we in some ways, depending on who you listen to, we already do. But I agree. I think we're still in the very beginning. And I don't know, it hasn't been validated. All of these very interesting findings that we can see, we can look and we can find differences between, attenuation for what we are calling high-risk plaques. We can talk about different, characteristics that may be associated with future risk of events. But as you know, I think it's very elusive to find that single plaque that's ultimately going to cause problems. In many ways, many people, including you and your group, have shown that it's more about the patient's substrate. And I think it all works hand in hand. And I think, though, we will find really interesting insights when we start to quantify plaque burden as opposed to just luminal stenosis, and with or without high-risk features. It's really calling into question these definitions we have about what is primary versus secondary CAD.
Thank you. We are very short on time. Short comment, Biykem and Joanna. Joanna, you have any comment?
Intrigued the rapidity by which they were able to pacifize the plaque. And that raises the question whether this should be an agent to be given before the PCI. But of course, the biological mechanism does not make sense for us to just try to do this because, yes, the reduction in the LDL and perhaps the reduction in the lipid composition is supposed to how this is to work. But I'm looking at the graphs, the rapidity that they were able to show these. I would like to see what was the earliest they were able to demonstrate the improvement in the plaque composition by OCT.
Thank you. Joanna?
Briefly, this is a trial obviously driven around imaging endpoints, not clinical endpoints. The difference in the safety events is so small, and the number of adverse events in the treatment arm is significant enough that it does make me worry about what the risk benefit is for this drug if it's ever comes into wider clinical use.
Okay, so let's then move into the next one. And let me tell you, is about hypertrophic cardiomyopathy again with mavacamten. This case is the so-called EXPLORER-LTE cohort of the MAVA-LTE study. I'm going to summarize the differences in this study with the one that we presented. This is not randomized. This is a longitudinal study. perhaps with less detail than the one that we began these discussions today, but it's longer. This is a project that goes for 5 years, and what they present today is the first year of follow-up. Remember, the other was significantly shorter. And also they look at escalating dosages of mavacamten. I just like to go, because of time, I like to go into the results. Just here we have, altogether were actually near 300 patients that were randomized, and they were followed for 1 year, 1 year and a half. And here what we have, actually very similar in the other study, a significant drop in the gradients from, in this case, from the median gradient of 45 to actually a gradient of 9. Then they also, with the Valsalva, the same thing. We have the left ventricular ejection fraction decreasing a little bit from 75 to 65. We know this, and we have been cautious about mavacamten, all these aspects. Reduction of NT-proBNP, 750 to 140. And then we have improvement in functional class, a slight improvement in the functional class. And altogether, certainly a positive study, except, you know, when you look at drug-related events, 17% at the 2-year follow-up, it gives you a little bit of worrisome situation because these are relatively short study with a very powerful drug. So this is what I can say about the summary. Very exciting, yes, but again, long-term follow-up with these very active agents really should wait. Joanna?
I think it's exciting. These are really impressive changes in both the LVOT gradient at rest and with Valsalva, with meaningful clinical endpoints for patients. So excited to see it in larger patient populations.
Biykem?
So mavacamten right now is a very exciting drug. It reduces the LVOT gradient for sure. I mean, we're seeing consistently across all studies, it improves the NYHA class, it improves overall symptoms, exercise performance, and some of the clinical endpoints. The question, though, is the safety. In all these studies, there's been a very close follow-up in the EXPLORER-LTE, as well as the Valor that we looked at. They were titrating according to the echo gradient. So I think the centers will now need to equip themselves of looking on how to titrate, because in this study, EXPLORER-LTE, about 5% of the patients had decline in their EF, whereby the medication had to be temporarily discontinued. It's reversible usually. Majority of these patients will normalize, majority, not all. So the question is, you know, knowing when to echo again and, you know, when to decrease the dose or how to titrate. And in this study, about 3% had QT prolongation and 4% had blood concentrations that reached that level which prompted the drug temporarily discontinuation. So titration, there is probably a ceiling. Yeah. And we need to know when to cut down and when to augment the dose. And I think that's going to be the trick in this implementation.
Any further comment, Paul or Viviany?
I think, you know, mavacamten, as Dr. Bozkurt very nicely stated, it's an incredibly powerful and interesting drug. And I think a theme that's emerged from some of our discussion today is that, you know, you have to balance your benefit with your side effect. I mean, it's amazing. It's a targeted inhibitor of cardiac myosin, right? And in what heart failure situation would that be beneficial? Well, HOCM. And so what's interesting though is, you know, we give it orally, whereas we're talking about potential new ways of giving therapeutics that are more targeted. If you could target it to the actual septum or the areas of the myocardium that really, really need that inhibition of myosin, you could talk about potentially limiting side effects. But I agree. I mean, the challenge is you're going to really need to actively manage dose titration and your monitoring strategy. And I think we saw that very clearly from EXPLORER-LTE, which was obviously a long-term follow-up relative to Valor HCM. And so for the very niche patient population, you know, that we're talking about, I think the risk benefit is absolutely exciting and thinking about it being there. But I think for a broader patient population, it would be very challenging.
We'll see the cost too, I think, so there is an issue. Paul, any final comment?
The only thing that I would wish is that we have a more diverse group of people that we're studying. This was a fairly homogeneous population that was studied. And I think that it behooves us to try to do a better job of having a more robust group of patients that we are studying that look more like the country.